connect to computer. So one of the things that has come up several times in the last 6 weeks is what we call trauma-informed care, TIC is its nickname. And it's important that you know that this was put in place for critical access swing beds in 2018. This is not a new requirement. Nursing homes, it was put in place in 2019. So actually critical access swing beds in general, got out on the front end of it. The trauma-informed care rules are very specific, both to what you have to do while you have the patient in, what we have to talk to the patient about, but also making sure that they are getting the services that they need afterwards if that is an issue for someone. So Becky, I can't see, can you tell me kind of by a hand raised how many people think that they are doing trauma-informed care now appropriately?
Well, actually, we just were kind of having a little bit of discussion, and I think there's a lot of area for improvement. So in this particular area, and just through COVID and everything was one of those things kind of put on the back burner. So
right. Okay. Let's see if I can get it open. I hate technology these days. First of all, it is required. Second of all, it's being surveyed now. And trauma-informed care in general is two sides of the equation that you have to pay attention to. One is the training for your own staff to be aware of what might be going on with the patient. So you should have some kind of screening tool in front of you when you are doing your interviews with the patient. And it's important also that when you are looking at that, that you realize there are things that people will not talk about. I often wonder, for instance, one of the questions in nursing homes is, do you feel suicidal? Though it uses slightly different language than that. And the question is, how many people actually answer that honestly when they are, and you don't know. So you have to kind of follow that side of the equation. But there are more things that cause trauma than what we think about routinely. So we have a huge influx beginning to hit this age group of veterans, war veterans. Both, I think we have a few Korean War people left. We certainly have Vietnam people hitting now. And we can have some people that sustain injuries in the Gulf Wars that would be coming through a swing bed program. At a minimum, particularly with the Gulf Wars, PTSD has been recognized in almost all of the veterans. So that's one thing that you look at. It can certainly be abuse in the home. It has a wide variety of items that can fall under that. And so we want to make sure that we are paying attention and interviewing at this point. My computer, I love it. I'm still trying to get in so I can see the screen. So trauma-informed care it can be, I would say, more these days for you guys and me. In Florida, we have more trauma that has come from natural disasters. If we look at the fires out west, if we look at the tornadoes that have been this spring, coming from Texas, it was a swath all the way up through Tennessee, Kentucky, and into New England. Hurricanes can be part of that. Any kind of other life events that hit us. Serious events include things like, again, if I go to the tornadoes, I have a friend that works for FEMA that's deployed in Kentucky right now, where nobody in a town has a home and they're having to fix up things. Well, they do what they have to do to survive, and then is the after effects of it And for healthcare, that means that we need to be looking at the triggers. If a person can name it, that's great. But us as medical professionals need to make sure at admission, again, during a stay, if we feel like there's an issue, we need to figure out what might be a trigger for them. Healthcare in itself can be a trigger, particularly for someone who has, for instance, childhood abuse or spousal abuse. Things being done with needles, things being done around an individual can mimic in their mind an abusive situation. So that's why this has come into play so much. So when the second part of it that I think is very important is that we should have not only training for our staff, we have to have a training that allows staff to understand what trauma survival they may have. They may be living in circumstances at home that aren't comfortable. They may be survivors of abuse. We have, again, war survivors that are staff members, and they may be able to control it most of the time, and then they're listening to a patient, it sets it off in them. So what CMS is really looking for is, one, that you have a policy, two, that you are doing ongoing training, which includes in-services. And that should be added as a new employee, that should be part of the package. But certainly, I don't care what you set up. Sometimes it's quarterly, sometimes it's annual. You can make a decision based on what's going on in your facility of people, types of patients that you're getting, that you can see trauma in, and again, are you noticing it in staff? And so they want to see these in-services documented. The second part of training is what I just brought up. Let's say that you have a schedule that you are training on trauma-informed issues, and you have an event. You have a bad winter where people couldn't get out and get food. You have mudslides. You have fires going through your area. When something is actually happening in real time instead of maybe 5 years ago, 10 years ago, or older, it's another time where we need to be doing the ongoing training that's specific to whatever event has gone through your population, both your staff and for potential patients. So the second step of that then is training your staff to make sure that they are reporting concerns about an individual. The individual may not even realize that they are showing signs. They may or may not. And it's important that it doesn't stop with a staff member that's noticed that it's taken back, and it's part of the care plan now. It's part of communication with the physician. It's part of a decision whether they need some mental health interventions. It may be part of eating disorders. Actually, we see more and more of that. So we are having direct care staff take the problems back to the team, and then we need to have care planning that addresses whatever we're seeing. So that's the signs and symptoms of it, versus us maybe knowing what the trauma is from it, or maybe we're in a discovery mode. So that means that's care planning. And that involves the patient and usually the patient family, as well as any appropriate staff. So as far as the patients, we start discussing what options they may already have or may want. Some of them may already be in counseling, and they just need to connect with that therapist or their physician if the physician's dealing with it. Some of them may not even realize until they've had a health event that something has been triggered. And then what are the options for them in your community? And obviously you want all of this documented. CMS has said they are, and they already are, they're going to increase the number of trauma-informed care or TIC surveys to make sure that all of this is going on. So that involves policy, for instance, on the training that you are providing to your own staff. What is to be documented when a staff member is sensing that there is something related to trauma? What is the follow-up that occurs at that point? When you are doing discharges, how are we discharging that patient? Are they going to see somebody? Have we recommended they see something? Or there are times that we're transferring them from a skilled setting, a swing bed setting, to, I'll say, psych or geropsych. The language for all of this that's formalized is in the state operations manual, and it's actually in Appendix PP. And I can't remember all of it off the top of my head, Becky, but I think they have the handout they can go through. The main thing is there's a reference in Appendix PP, which is the surveyor section of the state operations manual. If you are critical access, Section W addresses the hospital and the swing bed regulations for that setting. Appendix PP is the regulatory language of what the surveyors are supposed to ask and follow up on. So there will be a regulatory number in there for skilled. It's usually under 483 and some numbers or letters after that. And then you'll see a reference to an F tag. I think it's F726. Becky, you may have to help me there.
How about F741?
Okay, F741. I think 41 is the history of trauma or post-traumatic disorder. So
Correct.
you want to know, yeah, it could. Some of it, my brain's working anyway.
Yeah.
And so the importance of the F tag, which is a federal tag, is the regulation is listed there. We're supposed to train to that, address it. And then the federal tag is the write-up that comes from a state surveyor that says you're not doing something right, and potential fine comes from that. So back to it, it's your training, it's competency-based training is what I probably should say. It is addressing what the patient, how the patient is playing out. We see, for instance, right now, tons of patients with behavioral issues that are getting very agitated in nursing homes. I've seen more dementia with behavior issues in the last 2 years than I've seen in my entire career. I don't know if that's just because we're living longer and we're beginning to get some stages with mental difficulties. I do think some of it is the amount of things that we can have trauma around that are going on in our country. Again, I can't name a part of the country that hasn't had some kind of natural disaster or natural consequence these days. So it's really important that you get on that and that you have your policies, that you have your training in place, that your care planning notes are in place. And additionally, that there is training that is available for your staff, and that is documented. The staff, if somebody in your leadership team feels like they need additional help, then you can make a referral or suggest a referral to them. The one that I can tell you that is almost becoming, well, actually two, but one that is becoming a very common diagnosis is PTSD, or the post-traumatic stress disorder. And that used to be just for people returning from war. We're seeing it diagnosed a lot more. The other one is the combination of depression and anxiety, whichever that diagnosis is. We're beginning to see a lot more of that in our elderly population. So if we are having somebody enter our program and we see one of those two, both of those, because actually usually both of them are on if they have one or the other, and anything else leading to it, then we really need to figure out how we're going to help this patient while they're in your swing bed program, even though it is a short stay. So it is monitoring their needs, it's documenting their needs, it's your team training that's pretty specific. And the Appendix PP, you can find the regulatory language and sometimes the specific training that they are suggesting. The other advantage for Appendix PP is there's a list of questions in there that the surveyors must ask, and that's every skilled setting. It's not just you. And finally, I'm going to say, because the reason it's come back to my attention, and Becky and I actually had a side conversation on it, and she said there was some interest in on your side of it is there should be a trauma-informed care self-assessment in place, and it's called an organizational self-assessment. If you do not have that in place, you need to get it in place. And Becky, we had somebody that had a sample of that, correct?
Yes, yes. Actually,
Yeah.
I shared the Fostering Resiliency Change Package that is actually
Okay.
for primary care, but it's very applicable to critical access hospitals, and some are using it as their critical access hospital organizational assessment. Yeah, does a very nice job of addressing priority areas from education to screening to staff competency to leadership involvement, etc. So.
All right. So again, hands raised, because I can't see it, so you're safe. Hands raised or something in the chat box. How many of you believe you have this self-assessment in place currently?
And to raise your hand, if you hover at the bottom of the screen, and I'm trying to do that to show you. And I'm not, oh, no, I'm not seeing on here where they can do a reaction, Kerry, but if you put in chat,
Okay.
whether you're doing it well, why, we'll kind of take a look at your responses there. And so for you, if you hover at the bottom of the screen, it'll bring up your chat icon. You can click onto that, and then you can share right directly in chat.
And while they're doing that, Becky, go ahead.
No, I was going to say, and also if you have any best practices that you've identified, if you have already completed an organizational assessment, we'd be interested in hearing those too.
Absolutely. You do have a handout that has the FTAG, the regulatory language, some of the categories, actually a number of the categories that fall under trauma these days, because it is a very much a widened definition in the last couple of years, actually since 2018, since that's when this was put in place. I would recommend, in addition to this document we're asking about right now, that you check your policies and that it defines your training schedule and you're keeping to that schedule. I think those are the first three areas where you'd be most vulnerable. After that, the vulnerability would be in the documentation you find in the chart. So it may be something where you want to take, I'll say 6 weeks, and look at all the patients coming in the door, and in your team meeting or in your care plan meeting, if somebody is saying that they're recognizing there's trauma, has that been documented in the chart? Becky, or anybody think they're finding it, have it?
A couple of people have said they have not done an organizational assessment, and I think that's for the majority of our hospitals. Is kind of one of those things that through COVID has fallen through the cracks. And
right.
We do have a comment that they've completed a trauma-informed certification through IU. So any swing bed patients that trigger a yes to any of our trauma-informed questions on the comprehensive assessment, they receive a notification and update the care plan accordingly. So wonderful. Thank you for sharing.
That's great. All right. So again, the main pieces of paper that you have to have are this completed organizational self-assessment, any policies that you may have to have, your training schedule. I think the way you get started is you have to have some of that paperwork in place just in case there's a survey team, and certainly a questionnaire, a short list that you can find in the training material of questions to ask incoming patients. You probably have a lot of them already just in an incoming assessment, but you want to make sure all of them are there. And if something is identified, that then your whole team is notified of what might be the issue for the individual. I don't know if you have psych services available with your swing bed program or with your hospital more particular, but certainly somebody that works in psych could be providing training for your staff so that you understand what to look for, and perhaps maybe even to stop and identify some things that may be lingering in your own system that can be set off by somebody else's abuse. I think we have two reasons this has been coming up. One is we really are an aging population. So maybe not so much World War II anymore. I think there's one survivor of Pearl Harbor left, but we had Korean War that started in 1950. We certainly had the Vietnam War. The Gulf Wars went on for years and years and years and years. So we have kind of a constant number of that. We're recognizing more abuse settings and talking about it publicly than were done even 10 years ago. So I think that's a second set. And then I really do think the natural disasters all over the world, but particularly in our country, are impacting people pretty substantially. If people lose someone because of a natural disaster or lose their home and their belongings, those are serious consequences for people to kind of get their feet back under them. So this is a way for us to recognize and at least offer initial help. Becky, anything else we should be covering in this area?
Yeah, I noticed at the very top of the document that you provided, it says implementation for trauma-informed care and culturally competent care. And wondering if there's anything you need to share regarding culturally competent care and what surveyors may be looking for.
I will get some information to you. Generally, it is the difference in cultures. That's a word, a catch-all word that we're using for the differences in all of us these days. I mean, from the time I was in elementary school, I knew that the United States was a melting pot of all sorts of races, religions, and other cultural sensitive issues. So it is something where we want to be training our own staff about the differences. For instance, I live in Jacksonville, Florida, and we really have kind of three populations. We are, North Florida and South Georgia would have made a good state. So we are a southern state, so there are a lot of farmers, there are a lot of people, I won't say less educated, educated differently because they went into farming instead of going to college, for instance. That's one. Jacksonville has 11 universities. 11 universities, any university town changes a culture. You have educated or at least degreed people associated with a university or multiple universities, and that is another population that happens. And then we have in Jacksonville, our melting pot is Eastern Europeans. I have a friend that runs a restaurant that's Albanian. We have Romanians, we have Hungarians. We have a huge Ukrainian population, and trust me, we're discussing that in Jacksonville, how to support that population. As a result, we are getting refugees from Ukraine coming into Jacksonville, and everybody's kind of scrambling for housing for them. So there's something going on in every community. So the culturally competent is training your own staff to be sensitive to the differences that present themselves in the population that you are serving. But I have written that down, Becky, and I'll see if I can find something in writing because I don't have it obviously with me.
And Kerry,
that makes sense for everybody?
Yeah. One question that came in, and I'll kind of add to it here too, because to really kind of address trauma-informed care, it's kind of a challenging topic to really kind of put your arms around and make sure that you're covering all your bases well. What kind of things should hospitals have in place? Because as you address trauma-informed care, there may be triggers for staff. So hospitals that have a good trauma-informed care program in place, how have they addressed addressing trauma with their own staff as this subject is approached?
Yeah, I think it starts from two areas. One is if you're working with your patients and have done the training on trauma-informed care or trauma in general, that means you have resources that you should have identified for your community, for your patients going back in the community. That may be mental health services, that may be print materials. I think we have the SAMHSA, the SAMHSA, please don't ask me what those initials stand for, but they have a phenomenal number of materials on that deal with three big things that they've identified in an approach to trauma, which is event, the experience, and the effect. And they have materials around that that you can use as handouts. And so we build this network for our patients. Then we've got to turn around and look at ourselves. What are our support systems, you know, that we have internally? And I think this is where we need to talk to your leadership team as to what the availability for assistance might be. At a minimum, we would provide them with the same kind of handouts that we would any patient. More involved, it sometimes depends on the insurance that your hospital has for employees. Sometimes it will allow a number, like a limited numbers, I'll say 6, I don't know what it is currently, mental health assistance visits, to a therapist. But I think that's a discussion that you guys listening turn around and say, particularly if you are already picturing somebody in your head that you think has some difficulties, would be working with your leadership team to determine, since we're opening this Pandora's box for patients, that means we're opening that box also potentially for some of our employees. What are our steps? Obviously, first step is to identify it. Second step is what's the level of their need for assistance, and then what assistance can we provide them.
I did have a question come in. Is it only nursing staff that surveyors will be looking for ongoing education?
I would say if they're a good surveyor, it would not be just nursing staff. It's anybody that comes in contact with a patient. I'll give you an example from really the beginning of my career, a long time ago. I was in hospital administration, and we were doing some mental health classes then. I can't remember why we were doing with them. And one of our housekeepers, the guy was 6'8" and about 280 pounds. He was a gentle giant. He was wonderful with patients, always had a smile on his face. And we were training this, and I happened to be doing the training class, and he started crying. And it kind of shocked the whole room because he just always had a smile on his face. And he came up to me afterwards because I said, do we need to talk about something? Can we find some way to help you? And he said, nobody has ever asked me about my mental needs, ever. And it was just, he was so shocked that somebody was bringing it up, and it turned out that he had served in a war, and that he caught a lot of grief for his height. People thought he would be aggressive because of his height and weight, and so he had some issues trying to deal with that too. It made a huge impression on me that he was a housekeeper, had the same needs that we would have if we were a nurse or a physician or a radiologist. And actually, if you really want to think about it, housekeepers and dietary people have a lot of patient contact. Mm-hmm. So I think it would be wise to have your whole staff get the training for themselves, and then a short training on the awareness of what they might see in a patient when they're in a room, so they can pass that on to nursing. And then the nursing needs to get the most nursing and therapists, whether that's PTOT, speech, respiratory, anybody that's in direct care with license involved, we probably need to get them some additional training. Does that help?
Yes. Next question is, could you provide a good example of an individualized plan of care to address trauma-informed care? Want to make sure we're covering what surveyors are looking for and providing good care to the patient.
I think the SAMHSA has one. Becky, I will look for one and ship it to you, because I don't have one in front of me, but I know there's a care plan that's been built out as a generic version of this. Okay. Good question though, guys. It helps to start with something. as a basis.
Yeah, again, it's a concept that kind of takes a while to get used to, just putting your arms around it and addressing it appropriately. So,
Well, I've worked in skilled nursing for a long time, and we've almost done an avoidance of it. We have older patients that, for instance, do have some beginning dementia that have trauma, and they're beginning to act out for their trauma, but we never sat and discussed it with them because that used to be something you didn't talk to people about, whether it was even in your own family, let alone a patient. So again, this was started as a regulation for skilled in swing beds in 2018. Just like you're having problems with things that the pandemic paused all of it. And it seems in multiple levels, Becky, to me that CMS is making up for lost time and this current time trying to get through surveys, and this is coming up a lot. I would tell you very honestly, I don't know many people in my life. I can't even think of somebody that the pandemic didn't cause trauma. It changed our lifestyles. People were isolated. We were limited for travel. I have friends that their parents died and they couldn't see them other than through Zoom before they died. You all may have people that had COVID and were quite ill and could only talk to them by phone. I mean, I think the pandemic in of itself means all of us probably have some level of trauma, either as an initial trauma or a trigger to some past trauma in our lives. And we should be discussing that. We should have that as part of the discussion going forward.
no more questions in chat right now. But so Kerry, to kind of just quickly summarize it for everybody. So to make sure that we've addressed trauma-informed care appropriately and taking good care of patients, the things that CMS or the surveyors will be looking for is to make sure that we address it in the policies. We have documented ongoing training for staff. We include trauma-informed care as appropriate in the patient's individualized care plan. We do provide some community resources post-discharge and make sure that that's also a part of the plan, and make sure that we have an EAP program or an employee assistance program in place that they can go to, that as the hospital works on trauma-informed care, they can refer employees to should their own trauma be triggered in some way. And have
Go ahead.
I was going to say, and have a screening tool.
Yes, the screening tool is going to be important. And again, that organizational self-assessment has to be completed. It has to be in place.
Organizational self-assessment. Okay.
Which you've given in the packet, so they've got a baseline for that.
Mm-hmm. Yeah.
I'll work on these other two things, the culturally competent and a plan of care sample.
Okay.
See if I can't get those to you today.
Okay.
Heavy topic, everybody. I hope you're not depressed just from the discussion,
No.
but it is so important. And honestly, we covered up a lot. And I know my parents never could discuss, not just them, their friends never could discuss that somebody had depression. And that's one prior generation where it just wasn't talked about. So when we look at what we are doing health-wise with the body, all of you on the phone that are nurses, I know you can say in the same breath that you have recognized that it has been trauma, whether it's anxiety, depression, some major event, disaster that has brought on or at least complicated a lot of the health issues. We are trying to fix the body. So I think there's reason for this. It's just hard to get it started because we still don't talk about it well, and it's hard to get surveyed on it when we've just been through a pandemic. So first thing I would say, if a surveyor walks in and asks if you are doing anything with trauma-informed care, say we just started with a pandemic and we are trying to realize that everybody that just went through a pandemic has, trauma issues.
Also, another request from Crystal is if anyone has a trauma-informed care specific policy that they would share, why please do so, and you can send that to me. I will put my email address. I think everyone has it, but I'll just put my email address in chat, and I will get that to Crystal or anybody else who would like a copy of a policy just to springboard from. Anything else, Kerry?
Not today. CMS has been rolling out, they rolled out 286 pages of changes last week that primarily directly impact the PPS settings, not the critical access. The difficulty I have is I've already got 3 queries out to CMS on some things. I'm not sure how some of that translates to critical access swing beds yet. So if a surveyor happened to walk in right now, you might say you're aware that CMS just made some major changes, but that you're not sure what directly applies to critical access. And I'll bet the surveyor has to say the same answer at this point. So that's the thing that I'm going to be working on for probably the next 6 weeks, and I'm not alone. I work in a group of 10 consultants, and we're all scrambling how we're going to put it in place. And then there was no mention of critical access, and some of these were major changes. So we will be talking about that over the next couple of months as this evolves.
Thank you. A couple other requests to see someone else's policy to compare against their own and to develop potentially a new one too. So, okay, other questions?
I would say they have plenty of questions to go find some answers to right now, Becky.
Yeah, go and check out. So,
Yep.
All right. Well, thank you so much, everyone. We really appreciate your time today. Hopefully this has been helpful. And if we can help you along the way in making sure that trauma-informed care is addressed appropriately, please let us know, and we'll do our best to get you the resources that you need. Thank you so much. Bye-bye.